Good afternoon, everyone, and a very warm welcome to all of you. I am Batul, the moderator for today's session from ITCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, he needs no introduction, but yet it's our great pleasure and honor to introduce him. And he's none other than the very renowned obstetrics and gynecologist, Dr. Sujit Ash. Sir is MBBS, Diplomat of National Board in Obstetrics and Gynecology, Fellowship in Minimal Access Surgery, World Association of Laparoscopic Surgeons, Diploma in Gynecological Endoscopy at Kiel University, Germany, and Senior Consultant in Gynecology and Obstetric Departments at PD Hinduja Hospital, Mumbai. With Sir's wonderful insights and with his wonderful experience, we are going to talk about the topic for today, which is USG interpretation. Role of USG in pelvic pain and masses like ovarian cysts, uterine fibroids, endometriosis. Before moving on to today's session, let us have a brief look on what the topic says. So, ultrasound is a valuable imaging tool in the evaluation of pelvic pain and masses such as ovarian cyst, uterine fibroids, and endometriosis. It provides detailed anatomical information without the use of ionizing radiation, making it safe for repeated examinations, including during pregnancy. We welcome you all to our comprehensive webinar series on USG interpretation, role of ultrasound in pelvic pain and masses. This session will be focusing on the crucial role of ultrasound USG in diagnosing and managing common pelvic conditions such as ovarian cysts, uterine fibroids, and endometriosis. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Good afternoon, everyone. You can see the slide. Can you see the slide? Batul, you can see the slides?
Yes, the slides are visible. You can make it in full screen.
Yeah, it's full screen only.
No. As of now, it is not.
Okay.
No, not yet. I think you tried. I saw that you clicked on the slideshow mode.
Not yet?
Not yet.
Okay, let me close and start again. Yeah. Are we there? Can you see?
No, it isn't in full screen yet.
I'll begin with the presentation at places where I think we'll
Yeah.
concentrate more. Okay, so good afternoon, everyone. Sorry, there was a minor glitch with all these things. So I'll be talking today about USG, basically discussing pain in abdomen. So we all know that there are a lot of conditions that can present with pain in abdomen for a woman. And yes, when we think about pain in abdomen, the first thing that we think about is ectopic pregnancy, because that is where our mind goes as a gynecologist. But we also should remember that there are certain other causes which can lead to acute pain in abdomen for a woman. And this can lead to either immediate surgery or you might even overlook, and this can be debilitating for the patient. The common causes that we come across for these reasons are endometriosis, adenomyosis, pelvic congestion. It can be even related to any abdominal causes, which is non-gynae, which can be because of diverticulitis, appendicitis, renal calculi, or it can be because of obstructed hernia or incarcerated hernia. So this is all that we need to know about when we think about pain in abdomen for a woman. And this can be challenging not just for the ER doctor, but also as a gynecologist to find out what the cause is, because the signs and symptoms, what happen, are very non-specific. These patients present with nausea, vomiting, obviously pain in abdomen, and fever. And if you ask for the blood investigations, which are very non-specific, you might see leukocytosis with high WBC and neutrophil count. So, when you're thinking about such conditions, we always rule out pregnancy. That's the first thing that you do, either with blood beta HCG or urine beta HCG testing. And once you have excluded pregnancy, then your differential diagnosis can be narrowed down depending upon how good a history that you take, depending upon the clinical examination, and depending upon certain laboratory data. So these are the preliminary things that you do to find out or to ask for specific imaging studies, and that is when we move to ultrasound. We have reached at that level nowadays that ultrasound forms the basis or the primary imaging modality for diagnosing certain conditions or most of the conditions when it's come to pain in abdomen and acute pain in abdomen for a woman. This has also been supported by the American College of Radiology, which says that it's one of the primary imaging modality. And the benefit of ultrasound is that it helps us to diagnose accurately certain conditions, and it also helps us to effectively decide the treatment for those conditions. Yes, it can be used for both diagnosis and for assessing the complications. Not only for the abdominal and the gynec issues, it can be usually also used for non-gynecological conditions such as acute pain in abdomen because of diverticulitis or renal calculi. And the last line, if I say it's very controversial, but yes, sonologists are not always expert in their diagnosis. So therefore, when you need a differential diagnosis, you will rely on your clinical acumen and also on the imaging studies, and then you can decide the best diagnosis and the course of treatment for the same. And that is why we are having a discussion as gynecologists why ultrasound becomes important. Obviously, ultrasound will have its also pros and cons like anything out there today. The other imaging studies that you think about is CT and MRI. But then ultrasound and MRI are the only two modalities which has non-ionizing radiation for the patient, and that is why it's important in the reproductive age group. Ultrasound also is very easily available everywhere. You might find an ultrasound machine, but not a CT or an MRI system. And it is comparatively cheaper when you compare it with CT or MRI. But then it has the limitations. It depends on how good or bad the operator is, or how good or bad you can read the certain conditions. So for me, I always rely on my sonologist. Wherever you get it done, you'll always do it again with my sonologist so that she understands and she tells me the final thing, which will help me decide the mode of treatment. There might be certain technical limitations for an ultrasound also relating to the patient, which might be because of gassy bowel or because of not getting a proper position. But then again, this depends on the skill of the sonologist who will do the sonography and give us the diagnosis. The goals of doing ultrasound is to distinguish between the different causes which can lead to acute pain in abdomen. Once you identify the causes, it will help you decide whether you need to manage it conservatively, whether you wait on it, whether you give certain medical treatment, or you decide on the surgery for the patient. And that surgery, whether you require an urgent intervention, or whether you can wait over it and do it over time, or whether you need to do a percutaneous intervention. That is the goal of doing an ultrasound in obstetrics and gynec. Now, coming to the major thing that you come across, we'll be discussing in detail about the ovarian cyst, about endometriosis, and about PID and TO mass, because that is what we come across eventually whenever we think about pain in abdomen for a woman, which is acute. So, as we all know that when you do an ultrasound and when you do it for a perimenopausal ovaries, that is what you're looking out for. The perimenopausal ovaries are homogeneous and ecotexture. It might have several follicles and they're at a different stage of growth and they are usually seen at the periphery of the ovarian parenchyma. This is the basic thing. We all know as we study OBGY and the basic thing is that these follicles are under the dependence of FSH and LH, which will help it grow in the proliferative phase of the menstrual cycle. And one of the follicles will become the dominant one, which is called the dominant follicle, which will grow up to the size of 2.5 to 3 centimeter. This will rupture and lead to ovulation. I guess this much everyone is clear about. So if you see this sonography and you see the arrow which is there, that indicates the cumulus oophrus. That is where the growing dominant follicle will give way and give rise to the ovum. Now, what happens when the fluid in any of the non dominant follicle fails to be reabsorbed? That continues to grow. This is what we term as follicular cyst. In ultrasound, when you see for the follicular cyst, they are thin walled, they are avascular and mostly unilocular, and contain anechoic fluid, resulting in posterior acoustic enhancement. This is what you look out for. This can be thin walled, avascular, unilocular. The other part is a little confusing if you're not doing a sonography regularly, but these two, three things you can remember. And they can become large. They can range from a size of 3 centimeter to 8 centimeter. Usually they resolve on their own. If you do a sonography again after 3 months, give it time for 2 to 3 cycles. After 3 months, if you repeat it, they'll resolve on their own. But then, if there is any secondary hemorrhage, or if there's a rupture, or if this starts growing rapidly, then you might have pain in abdomen. So if you see this sonography, the grayscale that you see, there is a cyst which is there, which is clear, unilocular. That is a follicular cyst, which is there. So now what happens is throughout the ovulation, you have a corpus luteum that forms. So in the corpus luteum, it usually involute throughout the after the menstrual cycle ends by the time of the menstruation is done. Occasionally, fluid may persist in the corpus luteum also and will increase in volume. This can lead to development of corpus luteal cyst. Corpus luteal cyst, unlike they are slightly thicker and they have irregular walls. And this can depict peripheral vascularity because of hypervascularization of the luteinized granules and the theca cells. So when we compare it to the follicular, these are thicker, these have irregular walls, and this will show peripheral vascularity. While corpus luteal cysts are less common, they tend to grow larger, they can be more symptomatic, and will have more chances of getting hemorrhage because of their vascularity. So this is how you should remember when you're differentiating in a sonography for follicular cysts versus corpus luteal cyst. And even when you try to operate, at times you might just get a patient of pain in abdomen with a huge hemorrhage. So this is what happens that follicular cysts usually are simple and they do not have any vascularity, whereas corpus luteal cysts will have vascularity. So this is what you see again. And there are two images in the ovary which you are seeing. So in this, the right ovary shows a thick walled structure which you see, which has a peripheral vascularity, which tells about corpus luteum, which is there. Again, if you see in the sonography in this, there is peripheral ring of vascularity consistent with hemorrhagic corpus luteal cyst. While both these things can result in acute pelvic pain, depending upon the size and depending upon if there's hemorrhage which happens in, acute intracystic hemorrhage or intraperitoneal leak are the most common causes of having pain in abdomen in certain these conditions. The sonographic appearance of hemorrhagic cyst is complex and variable depending upon how much the bleeding is and at what stage of bleeding we are at when we look at the cyst on the sonography. The appearance of hemorrhagic cyst will slowly evolve over time, reflecting gradual change from acute blood to subacute blood to clot formation and finally clot retraction. So that is the stage that you see. There is acute bleeding that happens. After a while, this might settle and lead to subacute blood, which you might see as debris inside. Then it will form into clot, and eventually the clot will start reducing. That is clot retraction. Blood in blood as echogenic at the time of early hemorrhage, the blood products will gradually evolve and become progressively more hypoechoic over time. The classic appearance that you'll see whenever you think about a hemorrhagic cyst, which I'll show you in the next slide, it's called lace-like or spider web-like pattern. Why do you see this pattern is because of fine avascular septations, which are actually not true septations, but they represent fibrin strands which are formed because of the clot hemolysis. So this is what the pattern will look like. I'll quickly show you and then come back to this again. If you see the first picture, you'll see the trabeculations or the septation which is there. That is what that is what I mean by saying that you'll have a lace-like or a spider web-like pattern. The clot retraction will produce a thicker appearance, peripheral septations, or a mural nodule, which can appear like a vaguely triangular appearance. The blood products can also layer into fluid filled or fluid debris levels. So again, if you look at the picture, the first picture for understanding is the fine septation that you see, which are pseudotrabeculations. Towards the picture B and picture C, if you see, there's a triangular subsiding thing that happens in. That is the clot retraction, which is seen once the clot starts resolving. So this is majorly of follicular cyst or corpus luteal cyst and hemorrhagic cyst, which happens in and leading to pain in abdomen. Hemorrhagic cyst ruptures, complex or echogenic fluid fill in the pelvis can be visible. Occasionally, ruptured hemorrhagic cyst can result into hemoperitoneum with blood tracking into the upper quadrants of the abdomen also. In this also, you'll see that there was this lady who presented with pain in abdomen and there was bleeding in the peritoneal cavity, and we thought that there might be ectopic rupture, but as we went in we found that it was a ruptured hemorrhagic ovarian cyst, which was the cause of this hemorrhage in the or the hemoperitoneum for this patient. Coming to the second most common part, or the second most common thing that we see, is endometriosis. Ideally, endometriosis forms as one of the diagnoses, which is as an exclusion thing, where nothing fits in. You think about endometriosis and pain in abdomen, because the diagnosis of endometriosis is made by laparoscopy. It's usually found in pelvis, wherein ovaries are the major areas where you find endometriosis, and then in the pouch of Douglas. But you can notice it around uterosacral, broad ligament, and fallopian tubes. This can also be there in the uterus, where we term as adenomyosis because of endometriotic leaks. So yes, this is something which is very common these days, but again, it is referred to as an exclusion diagnosis, which is prevalent in approximately 10% of the women. We know what endometriosis is. It's ectopic endometrial tissues, which can result in endometriomas. Unlike hemorrhagic cyst, endometriomas can demonstrate a range of sonographic appearance, which can range depending upon the blood product degradation. That is what we've initially decided or spoken about in hemorrhagic cyst. Therefore, at initial stages, it might be a little difficult to find out or difficult to consider this and differentiate it. But over time, when you do a sonography for these patients, you'll have a cystic mass with homogeneous low level internal echoes, and that is what we call as ground glass appearance. So if you see the powdery appearance in the sonography with not much of peripheral vascularity, and this is what we call as ground glass appearance, which is one of the classical things that you see in endometriosis. Fluid levels and peripheral nodules result from clot retraction, which can also be seen. This we have discussed in hemorrhagic cysts. Multiple small echogenic foci within the wall of the homogeneous cyst are also quite typical. Doppler analysis is not very useful in endometrioma because there's not much which will lead to internal vascularity as we see in the corpus luteal cyst. One important part which we always come across, and it's a dicey thing whether to save the ovary or not, is ovarian torsion. Ovarian torsion happens when the ovary rotates around its axis or the pedicle. This happens, and then the blood supply of the ovary is compromised. And then the ovary becomes edematous, it becomes large, and it will lead to nausea, pain. And you're confused now, what should we do? Going in, and then do you remove the ovary or not to remove the ovary, and what do you do? The torsion, though it's uncommon, it is quite prevalent and poses a diagnostic challenge also. And it requires very prompt treatment because you need to save the ovary. Whenever you have an adnexal benign mass which is there, you think about these things which can happen. Commonly noted in pregnancy and commonly noticed in the younger age group and in dermoid, because that time the ovary is voluminous, the blood supply increases, so the ovary has more chance of undergoing torsion. They present with acute abdominal pain with non-specific vomiting and nausea. And sonographic appearance of ovarian torsion can vary from degree of pedicle twisting, degree of vascular compromise, the time of delay between you do the sonography and the onset of symptoms, and if there's a presence or absence of any concomitant ovarian mass or ovarian cyst. So, depending upon all these things, you can think about where the ovarian torsion and how much the size of the ovary will be, and how if you can save the ovary. Why does the edematous thing happens is because first time when the ovarian twisting happens, the lymphovascular pedicle is occluded, the lymphatic channels and the venous channels are occluded, and this will lead to engorgement of the blood in the ovarian parenchyma and lead to subsequent edema. As it starts going more, then the arterial blood supply is compromised. So enlargement of the ovary may appear relatively hypoechoic to begin with, and follicles are thought to become larger due to buildup of internal fluid, secondary to the venous and the lymphatic outflow obstruction. So this is what you can see, the enlarged area or the peripherally pushed in follicles which can be seen, and there's complete lack of parenchymal blood flow. So what do you do in certain such cases is you have to detwist. But similar appearance can happen because of massive ovarian edema, because which can look like a tumor enlargement, and happens because of accumulation of interstitial fluid and peripheral orientation of multiple follicles. So you have to differentiate in this way. Free fluid can accumulate around the ovary or in the cul-de-sac also. Vascular compromise as it goes on happening, then the blood supply will keep on reducing and it will become more heterogeneous with patchy in areas suggesting of hemorrhagic infarcts. Ultrasound may also depict any cyst or mass which has led to the torsion. Depending upon this, you have to decide the ovarian parenchyma may be viable, visible, and if there is any existing teratomas or, like I said, dermoid which can be present. And this is again one of the pictures where you see the 31-year-old lady presented with pain in abdomen, and we saw that there was an ovarian torsion which was there on the right side, and also on the left side, the patient presented with pain in abdomen. So what did we do? We did an untorsion. Ideally, 2.5 torsion. You just untwist the ovary, the blood supply will come back. Do not try to do the oophorectomy for this patient, and try to conserve the ovary as much as possible. If there is any existing cyst, try to remove the cyst. Otherwise, these patients recover well. The other clues that you can find is untwisted in the midline or cranial to the fundus of the uterus, or because of the bulky thing, it might be down posteriorly in the cul-de-sac, or it can be in the contralateral pelvis also because of a long round ligament. You might notice a whirlpool sign, which is because of the visible twisting of the vascular pedicle with or without demonstrable flow, which is there. And this is what is one of the classical things that you can see in the sonogram when you think about ovarian torsion. Color and spectral Doppler may show an absence of flow of both arterial and venous. One may also see absence of venous flow with persistent high resistance of arterial flow. Presence of normal color flow and spectral waveform does not exclude the possibility of torsion because the ovary has dual blood supply. It gets blood supply from ovarian artery and also from the ovarian branch of the uterine artery. Therefore, you should not miss out on the normal flow and not suspect a torsion. At the same time, when you have a torsion, don't try to think about oophorectomy because the ovary has dual blood supply and it will undergo, once you do the detorsion, the ovary remains viable. Okay. Another hypothesis, venous thrombosis and infarction produce symptoms before the arterial supply is compromised. Therefore, torsion, you might not see any whirlpool sign or you might not notice anything. Again, one of the reasons why you should not do an oophorectomy. Torsion may also be incomplete or even intermittent with transient restoration of blood flow in episodes of torsion. In appropriate clinical settings, when you have an enlarged unilateral ovary, you should always think about an ovarian torsion and do it color Doppler just to rule out the torsion part. And again, whenever you do a sonography of the single ovary where you're thinking that there's a torsion, try to compare it with the other side so that you find out whether there's a torsion, whether there's an enlargement of the ovary, and also you know that the other ovary is completely normal. Coming to the other important part, that is the TO abscess, the tubo-ovarian abscess, or the PID. It's a spectrum of infectious disease which can lead to endometritis, salpingitis, and oophoreitis, which is commonly caused because of chlamydia or Neisseria, but it can be caused because of other organisms also. And once you leave it untreated, this can extend and lead to pyosalpinx and collection of an abscess around the tube and ovaries, which can lead to teomas. Initially, the patient might present with pelvic pain, low-grade fever, and infertility and cervical motion tenderness. Fever and leukocytosis, as we discussed, are often vague and not very specific. Imaging studies, therefore, play a crucial role when you think about the diagnosis and subsequent management for the patients. Sonographic findings in the early things are you might not find a pyosalpinx or tubo-ovarian abscess because they might be very early, but you can find enlargement of the uterus and the ovaries with distinct soft tissue margins, thickening of the broad ligaments, and fluid which might be there in the cul-de-sac or the endometrial cavity. As the disease progresses, then you might start noticing the significant findings which are particular to PID, where you might have tubal signs where there might be dilated, fluid-filled, folded tubular structures in the adnexate. The luminal fluid might be purely anechoic or might have be having some floating echoes, and walls of the tube become thickened, hyperemic, and you might have a cogwheel appearance, which is specific because of thickened endosalpingeal mass, which is seen in the C diagram of the sonography that I've showed it to you. So you see the fluid-filled tube, which is there, which is hydrosalpinx or pyosalpinx, but a clog-filled appearance, which is classical of the folding of the endosalpingeal fold, which is classical of the tubo-ovarian involvement in PID. Inflamed ovary can also be attached to the tube and therefore lead to a mass, which is called as a TO complex, the tubo-ovarian complex. Persistent untreated disease can lead to disruption of the normal anatomy. There might be leakage which can happen. There can be a formation of an abscess, and this can lead to formation of a complex mixed solid cystic appearance in the pelvis. Treatment, it's an infection to treat with broad spectrum antibiotics. At times, the abscess might require drainage also, and these do lead to infertility. So, if required, you can also think of doing a salpingectomy or an oophorectomy if the damage is a lot, along with additional lysis. So, these are the major things that you always have to think about when you're doing a pain in abdomen in an acute condition for a woman in the premenopausal age group. And it's something which is very common, but a challenging thing to diagnose because there are numerous causes for pain in abdomen. Therefore, you need to take a proper history and do a proper examination so that you ask for a proper imaging study. Prompt initiation is the key, which will be aided with proper investigation, the imaging study which you'll be asking for. Because if you don't pick up an ovarian torsion soon, or if you let the TO mass progress, you might lead to damage of the ovary, which can lead to removal of the ovary at times. Since sonography is radiation free, it's inexpensive, and if you can read it well, this is one of the most important roles or most important tools in diagnosing and management for these patients. Thank you.
Thank you so much, sir. Thank you for
Thank you,
making
Batul.
us understand about the topic. Hello,
Yeah,
hello.
yeah,
Yeah.
Batul, I
So
can hear
moving
you.
on to
Tell
the
me.
question answers now. The first question is related to the integration. So how does the integration of ultrasound with other imaging modalities such as MRI or CT enhance the diagnosis and management of pelvic pain and masses?
When you think about CT or MRI, do it in very specific conditions, but then you'll have a correlating ultrasound for the previous thing. If you're thinking about any malignancy, then you ask for a CT scan with always contrast because it helps you to identify the spread of the malignant tumor, ovarian or uterine tumor. If you're thinking about multiple fibroid leading to some pain in abdomen because of degeneration, then you can ask for an MRI because of the mapping that you require. Most of the times we are lucky that we have ultrasound as gynecologists. We have one basic simple modality, and most of our treatment, most of the diagnosis is possible with ultrasound. So always ask for an ultrasound first. Reserve the CT MRI in these specific cases that I told you about, and that is how you integrate and define the diagnosis and the management for the patient. Next.
next question is related to how does transabdominal ultrasound differ from transvaginal ultrasound in assessing pelvic structures, and when should each be used?
Transabdominal is something which is not very uh, seeked out for. If you're thinking about any pelvic mass, as a gynac, I want to detect the pelvic mass first. So I always prefer a vaginal sonography, provided that the patient is not sexually active. If the patient has never been, like if the patient has never had sex, then we think about an abdominal scan. But for a gynac, a vaginal sonography is very important because your uterus is in the pelvis, your ovaries are there behind the uterus in the pelvis. So that is what gives me a better picture. It helps me to identify if there's any cervical pathology, any uterine pathology, or ovarian pathology better compared to an abdominal. Not saying that the abdominal is not accessible, it is, but then a preference is for a vaginal sonography. Abdominal sonography, just to find out the extent of the disease. If I'm thinking about the TO mass, I want to check in the abdominal cavity, then I ask for an abdominal also. Or if I have to give some treatment, I always have to check for the liver doing better. Or if I have to rule out any other pathology, if I have to think about a malignancy or something, then you can find lymph nodes or some metastasis. Again, the imaging study for them would be CT scan, but there's, yes, abdominal can be helpful, but as a gynac, vaginal sonography is what you prefer to reach out to the diagnosis.
Thank
Next.
you so much, sir. Thank you for answering this question and the other questions for our viewers and making them understand about the topic in such a better manner. With this, we would like to conclude the session here, sir. But before concluding, I would like to thank you for taking out your valuable time and for being here at our platform and sharing such wonderful presentation with our viewers and making them understand about it. So, before concluding,
Thank you,
sir, any
Batul.
last
Thank you.
message from your end?
Message is always what I always keep on saying: be good with your clinical acumen. Then only ask for an imaging study. You're treating the patient, not the report. So do your proper history taking, do a proper clinical examination, then ask for a pinpoint imaging study, and that will help you to manage your patient better. Thank you, Batul. Thank you, everyone.
Thank you so much, sir. Thank you.
Bye-bye.